Today we'll be talking about diabetes in pregnancy. It is a very important topic, just as like hypertensive disorders in pregnancy. So pregnancy is a diabetogenic state. What happens here is that insulin resistance. That means although the insulin is present, but it is not acting. Why it is not acting? Because the fetus has no energy source of its own. So the mother has to provide its all glucose to the fetus. Now when mother provides this glucose to the fetus, mother's glucose should not be well utilized, and for this reason there is insulin resistance developed. Now this insulin resistance is due to basically one hormone, that is HPL, human placental lactogen, and other hormones responsible are like estrogen and progesterone as usual. The insulin resistance is maximum at 24 to 28 weeks of pregnancy. So in diabetes, you must remember that the mother is also hyperglycemic, the fetus is also hyperglycemic, but the newborn is hypoglycemic. Now we will study the reasons for these cases. See, mother is hyperglycemic because the insulin is resistance in the mother, and therefore all the glucose that she eats is present there until and unless it goes into the fetus. Okay, the fetus is in case of hyperglycemia because it is getting a free and abundant supply of glucose from the mother. But how the newborn develops hypoglycemia, we have to see this. See, we will be seeing this in the video further. Okay, now maternal insulin cannot cross the placenta, and fetus therefore starts secreting insulin by 12 weeks. So now we understand the pathophysiology here. Pathophysiology is that the main source of fetal energy is the maternal glucose, and that by facilitated diffusion goes into the fetus through GLUT1 and GLUT3 transporters. See, maternal hyperglycemia leads to the fetal hyperglycemia. Do you understand now? What happens is that the maternal hyperglycemia, when it leads to fetal hyperglycemia, it stimulates the fetal pancreatic cells. तो जब fetus में hyperglycemia होगा तो क्या होगा कि fetus के जो pancreatic cells हैं वो stimulate होंगे, तो वहाँ पर beta cells की hypertrophy हो जाएगी. हाइपरट्रोफी होगी तो इंसुलिन का प्रोडक्शन इंक्रीज हो जाएगा. अब इंसुलिन का प्रोडक्शन इंक्रीज होगा तो उससे बहुत सारी दिक्कतें हो सकती हैं, जो कि हमारी मेन कंसर्न्स हैं इन गेस्टेशनल डायबिटीज़ मेलाइटिस. क्या क्या हो सकता है? देखो, फीटस की ग्रोथ के लिए सबसे इंपॉर्टेंट हार्मोन होता है इंसुलिन लाइक ग्रोथ फैक्टर्स. तो जितना ज़्यादा इंसुलिन होगा उतना चांसेस है कि आपका फीटस की ग्रोथ ज़्यादा होगी, क्योंकि यहाँ पर इंसुलिन बहुत है, इसलिए मैक्रोसोमिया हो सकता है. दूसरी चीज़ है कि इंक्रीज इंसुलिन लीड्स टू डिक्रीज प्रोडक्शन ऑफ सर्फेक्टेंट्स, जो कि लंग मेच्योरिटी के लिए इंपॉर्टेंट होते हैं. तो इसके लिए यहाँ पर भले फुल टर्म बेबी प्रोड्यूस होगा, लेकिन उसमें भी चांसेस हो सकते हैं कि रेस्पिरेटरी डिस्ट्रेस हो. और तीसरी चीज़ है कि अभी हमने बात किया था न्यूनेटल हाइपोग्लाइसीमिया होगा. वो क्यों होगा? क्योंकि आफ्टर डिलीवरी द सोर्स ऑफ द फीटल ग्लूकोज इज लॉस्ट बट द इंसुलिन इज स्टिल प्रेजेंट इन द बॉडी. मतलब डिलीवरी हो गई तो फीटल का जो ग्लूकोज का सोर्स है वो ख़त्म हो गया, क्योंकि माँ से बाहर आ गया है. तो अब लेकिन इंसुलिन तो उसी के अंदर प्रोड्यूस हो रहा था, तो इंसुलिन अभी भी है. सो इट lands up into fetal hypoglycemia. That is a serious complication. One thing you must also remember, that if a fetus is dependent on mother for its glucose needs, therefore when mother will be in a state of fasting hypoglycemia and also have postprandial hyperglycemia, what happens is that even though in the morning when the mother is in a state of fasting, the fetus is a the fetus is always having the source of glucose. So mother goes in state of fasting hypoglycemia. Now after eating food, that is postprandial, mother gets hyperglycemia because insulin resistance and glucose is not utilized immediately, and slowly it goes into the fetus. So these 2 points you have to remember, that mother is in a state of fasting hypoglycemia, and after eating, that is postprandial, she is in a state of hyperglycemia. Okay. So now let's talk about what is overt diabetes and what is gestational diabetes mellitus. See, if a female already has diabetes and then conceives, then she is said to have overt diabetes. But if she is a normoglycemic female and in pregnancy she develops insulin resistance, and because of which she develops gestational diabetes, then she is said to have gestational diabetes mellitus. मतलब अगर प्रेगनेंसी से पहले से डायबिटीज़ है तो ओवर डायबिटीज़, और प्रेगनेंसी के बाद डायबिटीज़ हुई तो गेस्टेशनल डायबिटीज़ mellitus. ठीक है, अब थोड़ा सा ओवर डायबिटीज़ के बारे में जान लेते हैं, क्योंकि हमारा बेसिक जो टॉपिक है वो गेस्टेशनल डायबिटीज़ mellitus है. तो ओवर डायबिटीज़ में क्या होता है कि तो आपको क्या पता होना चाहिए कि द फास्टिंग ब्लड शुगर लेवल शुड बी मोर देन 126 mg/dl और रैंडम ब्लड शुगर लेवल मोर देन 200 mg/dl एंड HbA1c का लेवल मोर देन 6.5%. And what is the best test to detect the congenital malformations in babies of diabetic mother? This is TIFA, that is targeted imaging for the fetal anomalies. ये 16 to 20 weeks में किया जाता है and it is done in all pregnant women. So now we come on to gestational diabetes, that is GDM. It is defined as carbohydrate intolerance of variable severity with onset of first recognition during the present pregnancy. Okay. So this is the definition, not more to understand, you have to learn this. Okay. Now what are the risk factors of GDM? Positive family history of diabetes, ठीक है, having a previous birth of an overweight baby more than 4 kg, unexplained perinatal loss, presence of polyhydramnios or recurrent candidal infection in present pregnancy, then persistent glycosuria, age over 30 years and obesity. So these are very important risk factors for GDM. Okay. Now we come on to the most important part of whole of this GDM topic, that is how will you diagnose the GDM. So you have basically two-step approach and there is a one-step approach, and there are three guiding principles behind these tests. Okay, so first we talk about the two-step approach that is given by ACOG, okay, that is American College of Gynecology. Okay, here you have two steps. The first step is a screening test and the second test is a diagnostic test of the confirmatory test. Okay, the first step is a screening test. Here the glucose challenge test is given and this is done at 24 to 28 weeks, and irrespective of the previous meal you have to give here 50 grams of glucose, and after 1 hour you will be checking the blood sugar levels in mg/dl. So if the blood sugar level is less than 140, then there is no chance of GDM. If it is 140 to 180, then maybe there is a chance. So you go on to the second step, and if it is 180, more than 180, then it is confirmed case of GDM and you do not need to do the second step. Now what is the second step that is done for 140 to 180 mg/dl blood sugar level? That is a confirmatory test and this is a glucose tolerance test. So in this case you have to ask the patient to have overnight fasting of at least 8 to 14 hours. Here the first sample is of fasting blood sugar, okay, and then after taking the first sample you give 100 grams of glucose and then take second sample after 1 hour postprandial, and take the third sample 2 hour postprandial and fourth sample 3 hour postprandial. So total samples taken are 4. Now if 2 or more than 2 samples are abnormal, then it is a case of confirmed diabetes. Okay. Now we talk about the one-step approach. Now one-step approach is of two types. One that is given by WHO and the another one is given by DIPSI. Now DIPSI criteria is most suited in the Indian setup, so you have to talk more about this. But let's first talk about the WHO criteria. In WHO criteria, directly at 24 to 28 weeks, you have to ask the patient to do overnight fasting for 8 to 10 hours. Okay? Then you take the first sample, that is fasting blood sugar sample, and then 2 hour 75 gram OGTT. Okay? Therefore the second sample is taken 1 hour ppbs and third sample is taken 1 hour after another 1 hour ppbs. Okay, so out of these three samples, if any one or more than one is abnormal, then the patient is diabetic. Okay, now we talk about the procedure. The procedure says procedure for the DIPSI, that is an Indian setup. Okay, so here what happens is that whenever a pregnant female has come for the first visit, okay, now irrespective of the meal, that is no fasting needed, you have to give her 75 gram glucose. Okay, and then you will be checking her blood sugar after 2 hours. So if the blood sugar after 2 hours is less than 120, then she is normal. 120 to 140, she is having impaired glucose tolerance. More than 140, more than equal to 140, then she is a case of gestational diabetes mellitus. And if it is more than equal to 200, then she is a case of overt diabetes. So how beautiful is this one? That is the DIPSI criteria that is suited for the Indian setup, because here the patients are actually less compliant and therefore this is very well suited. So here you get a complete picture of what the lady is, whether she is normal or impaired glucose or GDM or overt diabetes. Now we'll talk about the management of GDM. Okay.